welcome you. Bienvenue à la 26e édition du Symposium Montreal Live, the 26th edition. Actually, the new team is the Heart Summit, the Heart Team Summit, so it's our second year. And on behalf of Philippe Lallier and all the co-directors, I would like to welcome you to the start of the meeting. Tomorrow and Friday you have live cases, but for today, it's really a special session dedicated to out-of-hospital cardiac arrest. We have a great speaker, we'll have a great case to discuss, and we look forward, a small group, to have interaction with you this afternoon. And for those who don't know me, I'm Jean-François Tanguay. I've been working on the symposium, but now I pass the flame to a younger group, and it's great to have the next generation take care of this symposium. I would like to have the next slide, please. To thank our sponsor. If I could have the next slide, please. With the years, we've been working with different sponsors to help us organize all the live transmission, having speakers come and present. And again, with a challenging time, we were able to put up a really high-quality program over the next 2.5 days. So please consult the program. There's been some minor changes, and I think Philippe Lallier tomorrow will tell you the details of the changes for tomorrow and Friday. Today, the program is as is. Please, next slide. You may see that I'm co-chairing with Mark Liskowski, and we have great talk from Graham Wong on the update from guidelines, Annick Ducharme for the hypothermia section, and Francis Bernard is on his way in the traffic in Montreal for the best practices in neuroprognostication. That should be very interesting. Then Graham will come and present to us an interactive case for us to discuss with you. And we'll conclude this first part. The second part will be under the leadership of Johan Lamarche and Marc Jolicoeur, and will be the approach of the shock patient. And again, Mark Liskowski will be presenting the clinical approach, Vlad Javik, the pharmacology. And then we'll discuss the support device, the Perkin's device, and again, discussion with you. So without any more delay, I would like to welcome my co-chair, Mark Liskowski, present to you the objective of this afternoon.
Okay, thank you very much for the invitation to co-chair this session. I just want to quickly go over some of the objectives for this first afternoon session. So really just to look at some of the current developments in the recent guidelines of out-of-hospital cardiac arrest management. Dr. Wong will present the recent guidelines that he helped chair in terms of publishing with the CCS and CCU Director Committee. Dr. Ducharme will again speak about hypothermia, and Dr. Belmar will talk to us about neuroprognostication. I think bottom line, it should make it as practical as we can, because we realize that for out-of-hospital cardiac arrest, mortalities are still very elevated. As best as we can get people as early as we can to the hospital, and with early invasive intervention, we realize that we clearly improve the prognosis for many people. However, the rest of the phase in terms of immediate, early, intermediate, and recovery, a lot of morbidity, mortality still occurs during that. And we sort of became responsible as cardiologists working in our units to do the best we can to sort of help limit as much secondary injury to improve the recovery of patients to be able to eventually either get to rehab or be able to get home. In other scenarios, if we realize through neuroprognostication that the neurological outcome is dismal, I think it's our responsibility as well to consider offering organ donation to the family if that seems to be the pathway. Multimodal care has become sort of the standard for most physicians and other accessory staff and nursing in the CCU, and Dr. Wong will talk about that quickly, but it's more than just angiography and coronary interventions. I think it's a whole slew of more and more critical care associated management of patients. And as we can see, the whole neurological part that intimidates a lot of us is really critical in terms of determining what is the potential outcome of our patient who has suffered a life-threatening cardiac arrest. And I think Francis Bernard will help us sort of clarify exactly how our role is in all this algorithm, and as well as how intensivist neurologists can sort of help us clarify as accessory staff the best outcome of the patient. So we'll get started with Dr. Wong, who will start off with the initial review of the guidelines, and we'll keep the questions for the end of the session if there's some time left. If not, if there's any pressing questions, just let us know and we'll try to take note of them.
Thank you, Dr. Liskowski. So I would like to first of all start by thanking Dr. Tanguay and Dr. Liskowski for their kind invitation for me to speak. It's a privilege and an honor to come to this. I've spoken here before. I can attest to the high quality of science and clinical discussion that comes from this, so thank you very much. It's my privilege to present to you sort of a top-line view of the recent presentation and publication of the inaugural guideline for the care of the post-cardiac arrest patient. Next slide, please. Oh, do I do that? Oh, there we go. There we go. The guideline was very much a labor of love. It took us the better part of a year and a half. It involved the CCU Directors Working Group in CanCare, as well as CSIC, representing specialists in both cardiology as well as critical care medicine across the country. These are the primary panel. I had the privilege of co-chairing with Michelle Lemay from the University of Ottawa, and Dr. Liskowski and Dr. Tanguay were both in the primary panel. And next slide, please. Dr. Ducharme was one of our secondary panels. Next slide. So we all know that the background of out-of-hospital cardiac arrest has historically been very, very poor. Historical data would suggest that the survival to hospital discharge has been generally less than 10%. However, this is an extremely big clinical problem, and therefore lots of interest, lots of resources have been put to bear to try to improve this number. The majority, however, of research efforts and the focus has been on optimizing pre-hospital care of this patient to optimize the chance to hospital survival. With these interventions, emphasis on BLS, emphasis on optimizing ALS, increasing education in the lay public on BLS, survival rates have been better. So we're seeing a greater proportion of patients surviving to hospital admission. However, it is generally acknowledged that once they get into the hospital, adverse events remain very high, which continues to contribute to the high mortality and morbidity of these patients and decreases the likelihood of post-hospital discharge. Next slide, please. Why this is important, however, is that if a patient does survive the initial hospitalization, their chance of doing well long-term is very good. And so this is a patient population that, generally speaking, if we put the effort into going and optimizing their in-hospital care, we can get a very, very good reward. This is data from the Action Registry published by my colleague, Dr. Fordyce, when he was at Duke, and he looked at a very large cohort of patients who suffered a cardiac arrest and looked at their outcomes both in hospital as well as out of hospital. As you can see here, the patients who had cardiac arrest complicating MI had the expected high rates of hospital complications, cardiogenic shock, rearrest, heart failure, bleeding, and transfusion. However, if you survived a hospital discharge and you did a landmark analysis, next slide please, the adjusted hazard ratio for one-year mortality was virtually identical to those patients with ACS who did not suffer an acute coronary syndrome, a cardiac arrest with a hazard ratio of 0.89 with a p-value that's non-significant. And if you look at a double endpoint, next slide please, of hospitalization of one-year mortality, in fact, if anything, the patients who survived to hospital discharge did even better. Added to this is a very interesting analysis from Denmark that suggests that if a patient who has an out-of-hospital cardiac arrest survives to discharge, over 3/4 of them at 1 year will be gainfully employed, and therefore this is a group that traditionally has done poorly, but is a group in which we should put a lot of effort to bear because the rewards and the benefit of getting them through the hospital discharge and out of the hospital is very high. Next slide. With that in mind, there has been recent efforts by multiple international societies, ILCOR and the ERC, to go and provide a care map, so to speak, of in-hospital care. But although these documents were recently published, we felt that they were unwieldy, that they were difficult to understand, and therefore we believe there was room for a more practical, focused document and speaking to the more practical aspects of in-hospital care for the post-arrest patient, particularly as it pertained to the Canadian landscape. Next slide. We took the idea of what we call a critical care bundle, in which we packaged together a concomitant group of interventions that should be complementary and applied simultaneously, the idea being that multi-pronged approach to a critical care patient would lead to better outcomes. And there were 4 elements that we identified a priori that we wished to explore. One of them was targeted temperature management. Next slide. The second...
They want me to try if the PC works.
Okay. Okay.
So you have to push on the green one.
Okay. The second was coronary revascularization and angiography while in hospital. The third was multiple aspects of critical care management in terms of optimizing the biochemical, hemodynamic, as well as the hematological aspects of the post-arrest patient. And finally, some mention of the aspect of regionalization of post-arrest care, trying to extrapolate the lessons we've learned in other sort of major disorders that have benefited from regionalization, such as trauma, sepsis, and acute ST elevation. With that in mind, and you'll see this graphic a couple of times during the next couple of hours, this is how we envisioned this care bundle of the post-arrest patient. If you are a survivor, the aspects of the care bundle included these 3 aspects: TTM, angiography, and critical care management, all of which should be applied simultaneously, and we believe that all of these interventions are complementary to each other. So, I'm going to briefly go over some of the recommendations and some of the highlights of the recommendations, not going too much into depth. Starting off with targeted temperature management, I thought it was important for us today to sort of define what the guidelines came up with as the definition for targeted temperature management. We defined it as a strategy of intentional temperature management of a post-arrest patient, and there were 3 phases. The phase of active patient cooling, followed by the phase of subsequent rewarming, and then finally the phase of extended fever control. We believed, based on the literature, that this technology intervention would be most appropriate applied to comatose or unresponsive patients, which we defined as patients who had an absence of purposeful response to verbal commands. We chose not to use a GCS score, as we believe that the use of the score was very variable and very hard to apply at the bedside. Further discussion, however, on this, I'm going to leave to the capable hands of Dr. Anik Ducharme, who here is seen stick handling through cold very well, nicely. I think this is in BC, Anik. It's in BC. So she's going to do this much better than I. So I'm going to defer discussion on TTM to Anik. If then you go to the next aspect of angiography, you know, one of the issues is that there are both ischemic as well as non-ischemic causes for cardiac arrest. Obviously, if there is a non-ischemic arrest, the benefit of angiography is going to be blunted. We do know that in out-of-hospital cardiac arrest survivors, if they do subsequently pass away in hospital, the majority of mortality is actually driven by neurological and non-cardiac causes, and therefore what we had attempted to do was try to find a practical way to identify the patients in whom there was an important cardiac underpinning, from whom early angiography and revascularization for an ischemic culprit may improve clinical outcomes. We know that although the vast majority of patients who have a bad outcome in hospital have a bad non-cardiac outcome that leads to their demise, there is a high prevalence of coronary disease in survivors who are taken to the cath lab, highly selected, however, and there's significant selection bias involved in the calculation of these numbers from the retrospective data. It's very difficult a priori and also in retrospect to identify clinical and angiographic and patient-level characteristics that might define a patient who would have a cardiac underpinning, and we've attempted to go and identify some of these things to put to bear. We do know that traditional methods of identifying acute coronary syndromes in the absence of history ST shift biochemical abnormalities are unhelpful and not useful, and we therefore made some recommendations that they should not be used. But clinical judgment, unfortunately, is probably the best factor that we have at identifying someone who may benefit from angiography. What we do know is that if you do have acute ST segment elevation, that would probably be the strongest signal of benefit from angiography, and then you would follow the path of the ST elevation guidelines in which immediate angiography and revascularization would be indicated. The population of patients, however, who do not have ST elevation, those who have nonspecific ST changes, T-wave inversions, STT abnormalities, is a little bit more difficult. And we struggled with this in the guidelines. We had significant discussion between both the primary and secondary panels. We recommended that the patients with STEMI should go immediately to the cath lab with a strong level of recommendation, at least moderate quality of evidence. The evidence for taking patients to the cath lab without ST elevation, much less robust, and therefore that reflects the relative weakness of the recommendation for this cohort of patients. It is only a conditional recommendation and moderate quality of evidence. The timing of angiography in patients who do not have acute ST elevation, it is very difficult to find a time point, an inflection point in which there is benefit. We believe that there was no literature that gave us an actual time point for us to put in the guideline, and so we decided to lead with a recommendation to take a patient to the cath lab without ST elevation as soon as clinically possible. Because we know that the application of targeted temperature management is time sensitive, we did recommend that both angiography and TTM be initiated simultaneously if at all possible. Finally, speaking now to the area of critical care management, there were 4 aspects of critical care management that we felt were important when talking about the post-arrest patient, most of whom will be ventilated, most of whom will require some degree of hemodynamic support. And so we had recommendations speaking to the hemodynamics, the ventilation and oxygenation, rhythm control, as well as biochemical optimization. Most of the literature behind this had to be extrapolated from critical care as well as ACS literature. Very little data specifically spoke to the post-arrest population, but were acknowledged when present. I won't read right off the slide, but if you look at the manuscript online and in PDF, these are the various aspects of critical care management that we felt were important and applicable to the post-arrest patient. Temperature management requires an accurate assessment of patient temperature. We had recommendations on sedation and analgesia, the treatment of shivering, and the use of neuromuscular blockade, as well as optimization of hemoglobin, lactate, pH, blood pressure, and heart rate, as well as O2 levels. With respects to ventilation and oxygenation, we recognized that there was harm associated with both hypoxemia as well as hyperoxemia, and therefore we recommended that oxygenation levels be kept between 60 and 200, although actually I believe that subsequent to our guideline, there's been literature that suggests that a PaO2 level of around over 150 may also be associated with adverse outcomes, but we certainly do not want to promote superoxia in our patients because of the fear of precipitating oxygen radicals and its potential effects on the brain. Similarly, we wanted to target normal capnia. Both hypercapnia and hypocapnia were felt to be adverse in different mechanisms to the post-arrest patient, again speaking to its effects on secondary neurological insult following cardiac arrest. However, we acknowledge that the quality of the literature underpinning these recommendations were weak at best, leading to only a conditional recommendation with requisite low quality of evidence. In terms of the mean arterial pressure and hemoglobin targets, these were mainly extrapolated from the critical care as well as the ACS literature. The panel felt strongly that a mean arterial pressure of at least 65 millimeters of mercury be maintained. There was a suggestion in some studies that higher levels of MAP would be beneficial, but the quality of the literature underpinning those studies was felt to be quite poor, and therefore the consensus was that critical perfusion pressure 65 would be the target that we would aim for. Similarly, there is very little, if any, literature to suggest that a hemoglobin greater than 80 milligrams per deciliter in a critically ill population, including those with acute coronary syndrome, was beneficial, leading to this recommendation. But again, you'll point you to the fact that the recommendation is fairly weak, with conditional recommendation with requisite low or very low quality of evidence. In terms of hemoglobin, we had suggested that transfusions of packed red cells be considered if the hemoglobin dropped below 80, and that hemoglobin could be optimized further if there was clinical evidence of tissue hyperperfusion, but this would be a individual decision, as there was no guideline, evidence to suggest that this would be something that could be applied universally to the post-arrest population. Finally, I just want to spend a little bit of time on the concept of regionalization for post-arrest care. This was a very controversial topic that had a lot of discussion between not only the primary and secondary panels, but also with the CCS. We know that there are models of care for other critically ill patient cohorts, as we mentioned before, those with ST elevation MI, those with trauma, those with sepsis, in which regionalization of care and concentration of expertise and patients into a spoke and hub center has been associated with improved outcomes. There is a suggestion that a similar model of practice may benefit a population of out-of-hospital cardiac arrest survivors. Intuitively, it does make sense that a center that has angiography capabilities, ICU capabilities, advanced neurology capabilities would be able to offer more. However, we also recognized that smaller secondary centers could provide similar quality of care so long as they had access to expertise in these areas in a readily available fashion. Therefore, we believed that in terms of regionalization, we believe that a concept of virtual regionalization would be reasonable, in which local centers would adopt regional protocols unique to their particular geography and referral patterns that have been set in place for other systems of care. Finally, the use of prophylactic antiarrhythmic drugs is controversial. There is some literature that would suggest that continuing antiarrhythmic drugs that were used in the initial arrest protocol should be continued, with a suggestion that this will result in reduction of recurrent arrhythmic events in hospital. Therefore, we believe that it was reasonable to suggest this, although, again, the literature behind this is fairly weak. So I think I've spoken quickly, but I'm going to end here with a fairly busy slide, but this essentially encapsulates all the recommendations in a very detailed fashion in terms of the population in whom we believe these guidelines apply to, and in terms of the detailed aspects of both targeted temperature management, angiography, and critical care targets. I'd like to acknowledge the many individuals who helped in the preparation of this document, listed over here. And for those who wish to have a copy of the document, there is the URL, and it's in the January edition of CJC. I have 6 minutes left for questions. Okay, thank you.
That's perfect. Stay here, yeah.